Hello, and thank you for viewing this companion presentation to Chapter 385 of Humans and Win Neurological Surgery 8th edition. My name is Gavin Davis, and on behalf of co-authors Michael McRae and Julian Bales, I present this slideshow on sport-related concussion. The SCAT5 and Child SCAT5 are used to assist the clinician in managing athletes with sport-related concussion. This presentation discusses the components of the SCAT5 and the Child SCAT5 and highlights the differences between these tools. The SCAT5, the Sport Concussion Assessment Tool 5th edition, was developed by the Concussion in Sport Group of Berlin in 2016 and is for use by medical professionals only. The SCAT5 has been developed for the use of athletes ages 13 years and older, and the Child SCAT5 is for use by children ages 5 to 12 years. A different version, the CRT or Concussion Recognition Tool 5, has been developed for lay people, given that the SCAT5 may only be used by medical personnel. The CRT5 includes important red flags when, if present, require the assessor to call an ambulance. It also includes symptoms and signs of possible concussion and provides simple instructions on the appropriate management of concussion and advice on referring the athlete for medical assessment. The SCAT5 front page includes some very important information about the SCAT5. It stresses that the SCAT5 requires at least 10 minutes to perform, and it also discusses the role of pre-season testing. The importance of recognise and remove is stressed on this page. It also discusses that the diagnosis of concussion is a clinical judgment and that the SCAT5 is merely a tool to be used to assist the clinician in making the diagnosis. An athlete may still have a diagnosis of concussion even if the SCAT5 findings are within normal limits. Cautionary advice regarding airway, breathing, circulation and the cervical spine are also described. The immediate or on-field assessment of concussion includes the red flags described on the CRT5. The observable signs and the Maddox questions of immediate memory are documented, followed by the documentation of the Glasgow Coma Scale and a cervical spine assessment. The office or off-field assessment commences with an assessment of the athlete background. This is followed by formal symptom evaluation using the 22-item PCSS, which is a self-rated symptom scale using a 7-point scale graded between 0 and 6. At the completion of the symptom assessment, the athlete is asked to describe whether symptoms are worsened with physical activity or mental activity. And then an overall rating, self-rating scale out of 100 is documented by the athlete. This is followed by a cognitive screen which utilises the Standardised Assessment of Concussion, or the SAC. This assesses orientation, immediate memory and concentration. For immediate memory, the SCAT5 offers the choice of a 5-word or 10-word list, but on most occasions the 10-word list is utilised. It is important to document the time of completion of the immediate memory task, as later on during the SCAT5 assessment, delayed memory will be assessed and a minimum of 5 minutes must elapse between immediate and delayed assessment. It is noteworthy that the SCAT-5 has been developed and validated for use in English. However, validation in other languages is pending. A brief neurological screen is included in the SCAT-5. This includes simple cranial nerve assessment by asking the athlete to read a paragraph of text and also assessing simple external ocular muscular function. Cervical spine range of motion is assessed, in addition to the finger-nose test to assess cerebellar function. Tandem gait completes the first section of the neurological screen before proceeding to balance assessment using the modified BESS. This modification is such that the balance assessment is only performed on a firm surface, whereas the full BESS utilises both a firm surface and a foam surface, which remains an option. After completing the balance assessment, the delayed recall is performed, and as mentioned earlier, a minimum of 5 minutes must have elapsed since the immediate memory recall was performed. After completing the delayed recall, the decision section of the document includes the clinician's assessment and recommendations. Page 6 provides the clinician additional space to write notes as required, and the bottom half of the page includes a tear-off section to provide the athlete with appropriate post-concussion advice. Page 7 includes a detailed list of instructions, including a script with specific wording that the practitioner may use when assessing each task. The final page includes information on rest and exercise, graduated return to sport protocol, and a graduated return to school strategy. The child SCAT-5 is very similar to the SCAT-5, and here I will only discuss the elements that are different in the child version, and it is important to remember that the child version is only for use in children ages 5 to 12 years, whereas the SCAT-5 is used for adolescents and adults. For the immediate or on-field assessment, the child SCAT-5 does not include the Maddox memory assessment questions. The child SCAT-5 uses a different format for symptom evaluation. Here, the 21-item modified HBI scale is used. It includes both a child report and parent report. Each uses a 4-point scale graded between 0 and 3. At the completion, the child is asked to provide an overall rating out of 10, whereas the parent is asked to provide an overall rating out of 100. For the SAC, orientation is not assessed in children. For the digits backwards, in the SCAT-5 it commences with a 3-digit list, whereas for the child SCAT-5 it commences with a 2-digit list. For the reverse order section, in the SCAT-5 it uses months in reverse order, whereas in the child SCAT-5 it uses days in reverse order. For the neurological screen, an option is provided for the younger children who cannot read, whereby they may describe the contents of a picture. For the balance assessment, the single leg stance is not assessed in children aged 5 to 9 years, but is assessed in children ages 10 to 12 years. Page 6 includes a sample picture that may be used for the neurological screen for children who cannot read. Pages 7 and 8 are very similar to the format in the SCAT5 tool. It is worth noting that the SCAT5 and Child SCAT5 may be freely copied and distributed, but they should not be altered in any form without the express approval of the Concussion in Sport group. The SCAT5, the Child SCAT5 and the Concussion Recognition Tool 5 are free downloads and may be downloaded using the URLs listed here from the British Journal of Sports Medicine website. Thank you.